The scope of practice for emergency nursing encompasses the care of patients and their families throughout the continuum of health and the lifespan. Emergency nurses commonly care for patients with advanced, serious illnesses or injuries, or who are nearing the end of their lives. During this pandemic, it may be necessary to provide palliative and end-of-life care for the COVID-19 patients in the ED. This can place you in a unique position to change the focus of assessment from chief compliant and acuity to care that includes palliative and end-of-life care. Challenges to providing palliative and end-of-life care in the ED include time constraints, lack of space, lack of staffing, prioritizing of patient care, ED design, and the lack of formal education and resources on the topic of palliative and end-of-life care. Other challenges include the incongruity between the goals of emergency care and those of EOL care and the emotional burden you might experience when caring for the dying, particularly when resources are deficient. The fear and uncertainty related to the COVID-19 pandemic is real, and it is understandable. We are all feeling it, both personally and professionally. As ED nurses, we are being called upon to support each other in new and different ways, in all domains of life. Individuals and their families who are at highest risk for complications and death from this infection are especially vulnerable. No one can eliminate the uncertainty about whether they will get sick or how sick they will become. But as ED nurses, we can help to limit the uncertainty through proactively asking about the type of care patients want should they become severely ill. Knowing this information also limits the uncertainty for their loved ones and for the clinical teams who can confidently create a plan that aligns with what matters most to each individual. Given these potential consequences of caring for those receiving palliative or end-of-life care, it is important to be aware of the effects that ethical dilemmas and moral distress may have on each member of the healthcare delivery team. Resolving these ethical dilemmas and moral distress may require EDs to implement a more formalized approach, such as incident debriefing or the involvement of an ethics committee to help in navigating through ethically challenging situations. Be sure to ask your nursing director and educator what resources are available to you at your institution. Due to the sudden rise in COVID-19 patients, particularly those requiring end-of-life care, there is a need for early identification and intervention in the ED. You might have to have some difficult conversations, and in order to do that, you'll want to be prepared. Nurses can provide care in 4 domains: the physiological, psycho-emotional, social, and existential or spiritual domains. The role of emergency nurses in delivering palliative and end-of-life care is to always assess or inquire and identify interventions to help relieve suffering. These interventions can be delivered quickly, usually within 2 to 3 minutes. Again, the role of the emergency nurse is to open up the questions, gather some preliminary data, and then seek help from the colleagues or volunteers to continue the care. Here are some quick tips for each of the 4 domains. The physiological domain. Reports of patients who have COVID-19 unsurprisingly have significant shortness of breath or dyspnea. While we do not have any research on the use of morphine in COVID-19 patients, we know that morphine can palliate dyspnea and help reduce the distress of shortness of breath. The dosage of morphine is usually lower for dyspnea than for pain. Patients may also be experiencing pain or generalized discomfort due to fever, myalgias, and arthralgias. Antipyretics such as acetaminophen may be used. Some early reports from France recommend avoiding the use of ibuprofen, but this needs more research. The psycho-emotional domain. Patients who are in advanced phases of illness or near the end of life may struggle with their situation. Being present and allowing for emotions to be expressed and providing reassurance and comfort is essential in giving compassionate care. Acknowledge that this is a difficult time, and having them express their hopes and fears will relieve their psycho-emotional distress and suffering. Seek help from interprofessional colleagues or volunteers to provide additional support. The social domain. We are seeing in other countries that patients are dying alone and away from their social and familial networks. In palliative care, we consider the concept of family as being whoever the patient says is family, whether it is the family of origin such as blood or adoptive relationship, or family of choice, meaning the friends the patient chooses. This is very difficult not only for the patients and families, but also for the caregivers and health professionals. Providing frequent opportunities for communication with family by using technology such as video calls or through volunteers will help connect the patient with their family. The existential or spiritual domain. Patients whose illness advances them towards the end of life can experience existential or spiritual distress. Asking patients how they are coping with the situation will help you understand whether they are experiencing existential or spiritual distress. Merely asking how they are coping allows you to create a therapeutic relationship and helps you to identify which resources the patient will need. The Center to Advance Palliative Care has created a COVID-19 toolkit which includes communication tips. When you have a chance, check out the website and the toolkits. There is a lot of information available that will be useful. Here's an example from the toolkit. When talking to a patient that is deciding care for their loved one, a patient may say to you, "I don't think my spouse would have wanted this." The toolkit provides scripting suggestions to aid communication. In this case, you might respond by saying, "Well, let's pause and talk about what they would have wanted. Can you tell me what they considered most important in their life? What meant the most to them, gave their life meaning?" You may find these tools helpful to communicate with your patients in difficult circumstances. The National Hospice and Palliative Care Organization has many resources that can help as well. A great tool they've created is a COVID-19 shared decision-making tool. This tool assesses the risk for the patient, considers pre-existing condition, and helps determine a patient's overall risk level. Given this information, a patient has the autonomy to choose what advance directives they would like given their own COVID-19 disease process. This toolkit also provides healthcare staff with key decision points. The Center to Advance Palliative Care has a similar flowchart as well as guidelines for frontline providers to initiate palliative care. The skills that palliative care clinicians use at the bedside include communication, listening to what the patient and their families are feeling, providing clear recommendations for treatment and support for priority setting, and exhibiting a calm presence. ED nurses can use similar skills to help patients and significant others navigate end-of-life discussions during this crisis. One last thought. There are going to be some situations that will bring up strong emotions and moral distress. In disaster situations such as this pandemic, you will be faced with tough decisions at the fundamental basis of care, from the usual focus on an individual's welfare to a focus on the welfare of the population. Rationing care may become necessary because of limited resources. There will be difficult times. Be sure to take care of yourself and your colleagues. Resources used for the development of this recording include the Center to Advance Palliative Care, the National Hospice and Palliative Care Organization, and the ENA position statement, Palliative and End-of-Life Care in the Emergency Setting. Additional content review was provided by Garrett Chan, PhD, APRN, RN, FAEN, FPCN, FNAP, FCNS, FAAN.